Hello, this is Mrs. Coates, and we're going to talk about the concept of mobility. We're going to do the exemplars of arthroplasty, amputation, fractures, back pain, osteoporosis, osteoarthritis, osteomyelitis, and Parkinson's. I know that seems like a lot, but we'll get through this together. So as you can see here, the definition of mobility is the coordination efforts of the musculoskeletal and the nervous systems that cause purposeful movement of the body. This slide is just showing you the pathway behind alterations in mobility. We have skeletal dysfunction, which we will talk about fractures, amputations, osteoporosis. Neuromuscular dysfunctions deals with the nerves and the muscles. Here we'll talk about Parkinson's disease. We're not going to talk about fibromyalgia, but that's muscular dysfunction, so just the muscles. And then we have joint and connective dysfunctions, which we will talk about osteoarthritis and osteomyelitis. This acronym IMMOBILE is just to help you remember the assessment of the musculoskeletal system. So it's important to obtain a good history. We're going to assess the 6 P's: pain, paresthesia, pallor, paralysis, pulselessness, and poikilothermia. Poikilothermia is basically the temperature of the area. So is your extremity the same temperature as the room? Does it feel cool to the touch? Does it feel warm to the touch? That kind of thing. Musculoskeletal assessment, so that's when we're going to do an actual assessment of their strength, flexibility, movement of their joints, their ability to walk, sit, or do ADLs. We'll look at their mentation. Think about if you're injured and you can't get up like you normally do. So one may become bored, they may become depressed, have a decrease in communication. We need to assess their need for mental health, physical, occupational, and/or social work consult. Looking at their oxygenation, we all know that if we're not as mobile, we have the potential for complications such as atelectasis, pneumonia, DVTs, PEs, those kind of things. So we're looking at their respiratory rate, their breath sounds, their O2 sats. Are they producing a cough with sputum? We're looking at their bone demineralization. So we're going to assess their risk for fractures. We're looking at labs such as calcium, prealbumin, albumin, all of those lead us to their intake. We're looking at their integumentary system. We're at risk for skin breakdown, lack or decrease in cardiac capacity. So we're watching those vital signs, feeling those peripheral pulses. Are we losing circulation to that extremity? We're looking at skin color. We're also thinking about elimination because they're not up moving around. We're taking pain meds, so we're at an increased risk for constipation. We talked a little bit about some adverse effects, so think awful. Atelectasis can turn into pneumonia. Prevention for that, we're going to turn, cough, and deep breathe. We're going to avoid VTEs. All your patients in the hospital setting should be on some type of anticoagulant therapy, whether it be Lovenox, Avixtra, Eliquis, any of those heparins. They should be on SCDs. To be effective, SCDs should be worn 18 to 20 hours out of the day. So if you think about every time you walk into the room, their SCDs are hanging over the side of the bed, they're not really being effective for the patient. Wasting of bones, we're going to do range of motion exercises, making sure they maintain proper alignment so we don't get any contractures or anything like that. Functional loss of muscle, we all know if we don't use it, we lose it. So if they're not using their muscle, they're going to start losing muscle mass. Urinary stasis, and again, constipation. So here's some labs here. We're going to examine the patient's blood and urine to identify any presence or amount of chemicals and other substance in the body. The results may indicate primary musculoskeletal problem developing complications such as infection. So we're going to look at our CBC, that white blood cell count. We're going to look at that hemoglobin hematocrit, determine if we have any anemia. We're going to look at those platelets. We're thinking about maybe if they're going into surgery, we got to look at those coagulation times. We're looking at any electrolyte abnormalities. We're looking at that calcium and phosphorus, and remember, as we talked before, that calcium and phosphorus have that inverse relationship where if your calcium is high, that phosphorus is low. If the phosphorus is high, that calcium is going to be low. Your prealbumin and albumin, that's going to assess our dietary needs. We're looking at that ESR sedimentation rate. That's going to tell us if there's any inflammation in the body. Some diagnostic tests. We look at x-rays. As you can see there, we can visibly see breaks or things in the bones. CT scans tell us a little bit more than x-rays. Then we go into MRIs, bone scans, and DEXA scans. So a big one that we use, especially with tendons, ligaments, muscles, and diagnosing avascular necrosis, is an MRI. If you think about MRIs, it's a huge magnet in there, so we have to make sure that our patients don't have any metal implants, clips, pacemakers. We think about our veterans that may have shrapnel in there, if they have any metal studs or piercings. Those kind of things can cause injury to our patients if we're not aware that they have any of those things. We educate our patients, let them know that the MRI is very noisy. They have to lay still for 30 minutes on up. The biggest thing I've seen with patients is the complaint of claustrophobia. So they get real anxious before going to an MRI. So we may have to medicate before taking them to MRI. So here, the bone densitometry. You may have heard people talk about DEXA scans, and DEXA stands for dual energy X-ray absorptiometry. So that's basically the acronym for that, but it's used to evaluate bone mineral density. When looking at the body, they want to do a full body scan because sometimes your bone mineral density may be normal at one site and low at another site. If we look at the BMD of the heel, this can be used to diagnose and monitor the degree of osteoporosis, and we can predict bone fractures from osteoporosis doing a DEXA scan of the hip and spine area. So bone scans, this can be used to identify stress fractures. Basically, the procedure of a bone scan, they will inject the radioisotope through their IV. So if you're in the hospital setting, they usually come up to the floor, administer that IV radioisotope, and then a couple hours later, they come and get them and do the actual bone scan. It's important that we assess our patients for any allergies to that radioisotope, and we don't do this on patients who may be pregnant or breastfeeding. With that IV radioisotope that they do, they must drink plenty of fluids afterwards because we want to flush all of that out of their system. These are some invasive procedures or surgeries that we do. We're going to talk about a few of these. Arthroscopy. This is used to diagnose joint disorders. They actually take the fiber optic camera and can visually look at those joints. This is usually done in a sterile environment, usually in the operating room with local or general anesthesia. So afterwards, we want to teach our patients about signs and symptoms of infection, because usually this is done outpatient, so they will have to monitor this at home. We usually put a compression bandage over that for about 24 hours. And we have to educate our patients not to be doing any strenuous activity afterwards for a few days. So arthrocentesis is basically drawing that fluid off of a joint. So they use that synovial fluid to diagnose, or sometimes it's just pulling that fluid off of that joint to relieve any pain. Afterwards, we're going to apply a sterile dressing and use ice for 24 to 48 hours after to decrease inflammation and to help ease pain with that. So we're going to teach our patient again about fevers, risk for infection, monitoring for bleeding, monitoring perfusion, so any numbness or cool skin to that area. This is just a generalized slide about medications that you may see what related to the musculoskeletal system. So a lot of times, most of these, as you will see, are pain medications. So you have your NSAIDs, we have glucocorticoids, skeletal muscle relaxers, we've got our narcotics, and our centrally acting analgesics. I do see a lot of these on the ortho floor where we go. We do a lot of Ultram. We do a lot, of course, narcotics with the oxycodone, sometimes Dilaudid. We see a lot of Flexeril. And also we do see Mobic and Toradol a little bit on the floor. Arthroplasty is the surgical removal of diseased joints and replacing it with a prosthetic or artificial components made of metal and or plastic. We do these in patients for osteoarthritis, osteonecrosis, rheumatoid arthritis, some type of trauma such as hip fractures, and congenital anomalies. This is pretty much your joint replacement. So we have total joint arthroplasty, which is your total joint replacement. It involves replacement of all components of an articulating joint. So total knee replacement is replacement of the distal femoral component, the tibia plate, and the patellar button. Usually they do this when all other conservative measures have failed. A unicondylar knee replacement is when that joint is diseased, so they have to replace one compartment of the joint. Total hip replacement replaces that acetabular cup, the femoral head, and the femoral stem. And then we have a partial joint replacement. Usually fractures of the femoral neck can be treated only with the replacement of that femoral component. Some of the most commonly replaced joints include the hip, knee, and fingers, but we can also do replacements on shoulders, elbows, wrists, ankles, all of those things. So as you can see here to the right, it's kind of what it looks like if they're replacing a joint there. And you can see the hip joint, you can see the knee. And here's just another view of that knee replacement there and that hip replacement. So when would joint replacements be contraindicated? If a patient has had a recent or if they have an active infection, it can cause those bacteria to migrate to the surgical area and possibly cause the prosthesis to fail. If they have arterial impairment to the affected extremity, it's not going to heal. The client inability to follow post-surgical regimens and a comorbid condition such as uncontrolled diabetes or hypertension, advanced osteoporosis, progressive inflammatory conditions, unstable cardiac or respiratory conditions. These are all going to make the healing process and sometimes even the artificial joint not to be able to do what it's supposed to do. So preoperatively, we're going to review our diagnostic test results. We're looking at that CBC, looking at their white blood cell count, their hemoglobin. They may postpone if their hemoglobin is too low. Looking at those platelets, we want our body to be able to stop any bleeding. We're looking at the electrolytes, BUN, creatinine. We're assessing their surgical readiness. Again, ruling out anemia, infection, or organ failure. We use something called epoetin alpha that can be used for those with anemia preoperatively so that they are kind of built up before surgery. Going to look at a chest x-ray. We don't want any pulmonary surgical contraindications such as infections or tumors. And we're going to look at that ECG. We're going to gather a baseline rhythm to identify any heart contraindications such as dysrhythmias. So we all know education starts pretty much when you first see the patient. So preoperatively, you're going to prepare them for post-op, right? We're going to go ahead and talk to them about intensive spirometry, talk about any transfusions. Typically, we get consents for that before they go into surgery, just in case they need them during surgery. We're going to talk about the surgical drains, dressings, pain control, pretty much everything. Going to introduce it so that they're prepared post-operatively. Autologous donation, blood donations. The client donates blood prior to the procedure to be used during or after the procedure. So if a patient has a weird blood type or something, they have a lot of antibodies in their blood, they may want to do this donation beforehand. If they're coming in from outpatient, we got to talk to them about how to prepare. They're going to scrub, typically with CHG, the night before and the morning of surgery to decrease that bacterial count on the skin. They're going to wear clean clothes and sleep on clean linens the night before. We're going to talk to them about which of their home medications they're going to take before surgery. So during surgery, they may have general or spinal anesthesia, so we have to prepare them for that. Making sure joint components are removed and replaced with artificial components. Those components can actually be cemented into place, and those that do not use cement allow the bone to grow into the prosthesis to stabilize it. With those that don't use cement, weight bearing is delayed several weeks until the femoral shaft has grown into the prosthesis. All right, so post-operatively, we're going to get physical therapy involved. Typically, they can be discharged home or to an acute rehab facility. If they're discharged home, typically they do outpatient or in-home therapy, usually about 4 to 6 weeks after. We're teaching them to monitor for evidence of infection, how to care for their incision, monitoring for DVTs, so that would be that warm redness, swelling, a little bit of pain in the calf. We're teaching them about signs and symptoms of pulmonary embolism, that shortness of breath or chest pain, and bleeding precautions, especially if your patient is on some type of anticoagulant. Sometimes they stop that anticoagulant before surgery, and then they have to continue that after surgery. So after surgery these days, we're getting those patients up out of bed pretty much that same day, if not one day after surgery. We need to make sure that we are teaching them about walkers or crutches and making sure they know their weight-bearing prescription from the physician. Sometimes they do insert drains to keep that bleeding or any fluid draining out of that area. And we're going to prevent infection. We're going to prevent DVTs, and we're going to provide education for our patients, and pretty much most of them are going to rehab afterwards. With the knee, we're going to encourage active flexion exercises using that CPM device, educating them that CPM device at home needs to stay on 8 or 10 hours a day, and basically we're taking it off when eating to give them a break. All right, so we do see a lot of hip fractures, especially in our elderly patients. The most common cause of hip fractures are falls with our elderly patients. Things that increase their risk are decreased bone density and muscle mass, balance problems, inactivity, problems with vision and balance, and these hip fractures can be life-threatening to them. So again, we talked about the hip flexion. We don't want them to flex that hip more than 90 degrees. We're going to avoid that internal rotation, no crossing of the legs, and going over hip precautions with our patients. So one of the interventions we do, as you can see here, this is a picture of an abduction pillow. So basically that hip's not to be flexed more than 45 to 60 degrees. So we're not going to raise the head of the bed more than 45 degrees. We're going to educate our patients about not crossing their legs. So this pillow also allows for that, especially when we're turning them, having to clean them, helping them use a bedpan, things like that. We definitely do not want to have that hip pop out of joint after surgery because the doctor's not going to be very happy with you. So I have heard stories of other nurses saying that they've been caring for patients, maybe helping them to the bedpan, and they heard a loud popping noise, which tells you that that hip has popped out of joint and we need to contact the doctor ASAP. So here's just some post-op care for hip fractures, just things you need to be aware of, preventing those complications down there, helping them control their pain, keeping that leg basically immobile, watching for shortening and external rotation of the leg, preventing atelectasis, making sure we're preventing DVTs, turning every 2 hours. As you can see, these are a lot of interventions that we do. What are some complications? We think we've been through surgery, so what are some things after surgery? If we've lost blood, we have hypothalamic shock, again, atelectasis, pneumonia, urinary retention, infections, DVTs, PEs, constipations. A lot of times on the ortho floor, they won't even discharge them until they've had a bowel movement after surgery. We're going to help relieve their pain. Sometimes they put them on PCA machines. Other times we're medicating them pretty much around the clock. Educating them on different types of pain relief, repositioning, distraction, imagery, those kinds of things. A lot of times you will see them using ice packs, keeping those extremities elevated and immobilizing to help with that pain. Amputation is the removal of a body part, often a digit or a limb. Pretty much it's the consequences of vascular disease such as diabetes. These account for about 54% of amputations, and trauma accounts for about 45% of them. Amputation is used to relieve symptoms, to improve function, and to save or improve the patient's quality of life. Amputation is the removal of a body part, often a digit or a limb. Pretty much it's the consequences of vascular disease such as diabetes. These account for about 54% of amputations, and trauma accounts for about 45% of them. Amputation is used to relieve symptoms, to improve function, and to save or improve the patient's quality of life. Amputations are performed at the most distal point that will heal successfully. The site and extent of an amputation is determined by circulation in the area and whether or not necrosis is present, and functional usefulness, whether or not it meets the requirements for the use of a prosthesis. A BKA, or below the knee amputation, is preferred over an AKA, which is above the knee amputation, because of the importance of the knee joint and the energy requirements for walking. A knee disarticulation, or amputation through the joint, is most successful with the young, active patients who can develop precise control of a prosthesis. When AKAs are performed, all possible length is preserved. Muscles are stabilized and shaped, and hip contractures are prevented to maintain ambulatory potential. Upper limb amputations are performed with the goal of preserving the maximal functional length. The prosthesis is fitted early to ensure maximum function. So the plan of care for amputees, we're going to think about the acronym AMPUTATE. So we're going to A, assess neurovascular signs, looking at those 6 P's that we've been talking about, monitoring for infection, looking at that drainage from the wound site, looking at those incision sites, position the stump on a pillow to decrease edema the first 24 hours, then promote the dependent position to promote blood flow. You need to implement shrinkage interventions, decrease that edema to prepare for a prosthetic fitting, and we're going to keep that stump area clean, free from infection. Treat the pain. We may have to medicate if they're having that phantom pain. Sometimes just having the patient visually look at where the area is where their limb used to be. We're going to avoid prolonged sitting, try to prevent contractures. We're going to educate about correct positioning, range of motion, lying in that prone position several times a day, and we're going to encourage and support the grieving process. We're going to refer them to support groups. PT/OT are going to be working with them. Prosthetic designing is going to start about 2 to 3 weeks after they begin wearing the elastic wrap or shrinker sock. We're going to talk about fractures and dealing with those. As you can see here, these are just a few of the different fractures that we may see. We have that green stick fracture. As you can see, it is broken on one side and it's bent on the other side. Spiral fracture kind of spirals around the bone. Comminuted is broken into fragments. Transverse, it goes straight all the way across, and then we have those compound fractures that come through the skin. And as you can see, the last one, the vertebral compression, is where those bones are actually compressing on each other. There are 3 different types of hip fractures. We have fractures of that extracapsular area, as you can see there between the subtrochanteric and trochanteric regions. We also have our intracapsular fractures. These are fractures of the neck of the femur. These actually can damage the vascular system that supplies blood to the head and neck of the femur, and the bone may become ischemic. Avascular necrosis is very common with patients with femoral neck fractures. And we also have the periprosthetic fractures, which are fractures to the regions surrounding the prosthetic joints if they've had joint replacement in the past. I'm not going to get too much into the pathophysiology of this, but basically you can go to your book and read about the patho of a fracture. But basically when a bone is fractured, it begins that healing process to reestablish continuity and strength. The bone fragments are not patched together with scar tissue. Instead, the bone basically regenerates itself. The patho of this, we have 4 different stages. The first one, the hematoma forms, and then the second stage, where that cartilage callus forms over the bone. The third stage, we have a bony callus, and then the 4th stage, remodeling occurs. So we all know that if we have a broken bone, we have a fracture, it's going to be painful. We may lose function of an extremity. You may see some deformities, sometimes the shortening of the extremity. May hear or feel crepitus, as those bones rubbing against each other. And typically we're going to diagnose by their symptoms and x-rays. So what's our goal for treating fractures? We're going to control that hemorrhage, provide pain relief, prevent ischemia, and remove potential sources of contamination. To treat this, we may apply cast. The patient may be in traction for a little bit of time, and they may go to surgery to repair a fracture. So caring for patients with fractures, we're going to do a system-specific assessment for pain and assessing those 6 P's, immobilizing that affected limb. We're going to monitor their diet. They may need to increase calcium and vitamin D in their diet. increased protein, the equipment we may use, any assistive devices, walkers, crutches, traction casts, and we're going to control their pain, address any injuries, immobilize again, and elevate that extremity. Okay, and if our patients need a cast, we need to educate them. We need to talk about the type of cast they're getting. They have plaster cast and fiberglass cast. Plaster casts are a little bit heavier. They take a lot more longer to set, and they are not water resistant at all. The fiberglass casts are a little bit lighter for the patient, a little bit faster setting time, and they're a little bit more water resistant than the plaster cast. So we need to explain to the patient why they need this cast and what to expect during the casting process. So as that cast is drying, they need to keep it elevated off of a surface. We don't need to put any indentions or flatten that cast out at all, because those can cause pressure points and have devastating effects for the patient. We need to educate on how to care for their casts at home. Do not get them wet. They may want to keep that extremity elevated to help ease some pain, ease the swelling, not to stick anything in the cast, and not to stick things down there and to scratch an itch or anything like that. So traction uses a pulling force to promote and maintain alignment to an injured part of the body. The goals of traction include decreasing muscle spasms, which decreases pain, realignment of the bone fractures, and correcting or preventing deformities. The type of traction, amount of weight, and whether or not traction can be removed for nursing care must be determined to obtain its therapeutic effects. Traction is used primarily as a short-term intervention until we can get them into surgery or apply an external or internal fixation device. These modalities reduce the risk of disuse syndrome and minimize hospital lengths of stay, and often allows the patient to be cared for in the home setting as opposed to in the hospital setting. So here are just some principles of effective traction. We know that with weights on one end, we need a counter traction on the other, which is usually the patient's body weight. We know now that skeletal traction we can never interrupt, but skin traction may be ordered for intermittent traction so we can do nursing care. We need to look and make sure that those weights are hanging freely and not resting on the floor. The ropes are unobstructed, and making sure there are no knots within those ropes that can cause problems with the traction. This is just a picture that shows you those two vectors of force keeping that fracture aligned. So the use of traction has decreased significantly over the past few years due to advances in the surgical reduction of fractures, shortened lengths of hospital stay, and research that states the effectiveness of its use. But you still may see them a little bit in the hospital setting. So there are some different types of traction you may see. So manual traction can be applied with the hands, and this is a temporary traction that may be used when applying a cast or giving skin care under the Bucks traction extension foam boot or adjusting traction apparatus. So skin traction, as you can see, we talk a lot about Bucks traction. That'll be the one that you see most often. It can be used intermittently, and the pulling force is applied by weights attached by cables to usually a boot that goes around the patient's extremity. And the weights that can be used with this is about 3 to 8 pounds. And if they're in pelvic traction, that's usually a little bit more, 10 to 20 pounds, depending on the weight of the patient. Skeletal traction is often used when continuous traction is desired to immobilize, position, and align a fracture of the femur, tibia, or cervical spine. It's used when traction is to be maintained for a significant amount of time, when skin traction is not possible, and when greater weight is needed to achieve the therapeutic effect. So basically with skeletal traction, it can hold a little bit heavier weight than skin traction, usually about 25 to 40 pounds on the end of that. And with skeletal traction, basically they're putting pins or bolts through that bone and then attaching the traction device to that. As you can see here, internal fixations is when you hear people talk about they have rods or screws within a part of their body. An external fixation, we will see in the next picture, is pretty much outside of the body. So here are some different types of traction. Right there in the middle, you'll see the halo traction where those bolts are coming out through the skull and supporting that head to keep them immobile with a cervical fracture. The top fracture shows you that traction connected to the boot, which is a form of skin traction. We don't just do lower extremities, as you can see in the upper right hand corner. We also do, the upper extremities. And then down in the lower left hand corner, you can see a form of skeletal traction. This is your external fixation device. As you can see, it does look pretty painful, but they can go home with this, so we need to teach them meticulous pin care, making sure that they are cleaning pretty often, and we usually use the CHG nowadays to keep those areas clean, around those pin sites. So when we're caring for patients in traction, we're going to remember this acronym. So we're going to do range of motion per protocol and maintain that patient's body alignment, prevent any respiratory complications. We're constantly assessing those 6 Ps. We're caring for those pin sites, which nowadays we do with the chlorhexidine solution. We can provide a trapeze for the patient, which is a device above the head of the bed to help them move up in the bed. We're going to prevent infection. Our ongoing assessment, we're going to monitor those traction weights, making sure they're hanging freely and not laying on the floor. We're assessing the entire system with the pulley cables and the ropes, making sure they're free of knots. And with the halo, we're going to make sure that we have a wrench nearby or on the patient taped to the front of their vest for emergency situations where we can remove that halo if needed for any complications. So what are some complications or potential problems that may arise with patients in traction? If they're in traction, usually they're kind of bedridden, so we have risk for pressure ulcers, again the atelectasis and pneumonia, constipation, anorexia, urinary stasis and infection, and of course blood clots. Complications of fractures. We have shock, fat embolisms, compartment syndrome, delayed union and non-union, and reaction to internal fixation devices. So shock. How are we going to recognize shock? What are some signs and symptoms of shock? So basically, hypovolemic shock usually results from hemorrhage, especially with your larger fractures such as your pelvis or with any open fractures. So how we're going to notice a patient going into shock? We're going to look at trends of our vital signs, monitoring what our patient looks like, any complaints from them. Usually with shock, you're going to see that blood pressure start dropping, that heart rate going up, and a patient's mental status may change. They may start becoming a little bit more drowsy, changing their level of consciousness. So basically, we're going to have to stabilize that fracture ASAP to prevent further bleeding. We may have to give them blood, and of course, we're going to give them pain medications. Fat embolism syndromes can occur with any fractures. We see them more often with large bone fractures, and basically it is what it sounds like. It's fat droplets kind of like when we get our blood clots. It's a foreign debris that can travel through the circulatory system and land in the brain. It can land in the lungs. It can get through the heart. So we want to be aware of that. These can be pretty rapid, anywhere from 12 hours up to 3 days. This can occur. So to prevent it, we want to reduce those long bone fractures as soon as possible after injury. Some of the signs and symptoms that you're going to see is respiratory distress, increased heart rate, maybe altered mental status, decreased level of consciousness, and a petechial rash on the chest, axilla, and coming up the neck area. So if we suspect this, we have to notify the doctor immediately, start them on oxygen, go ahead and start some IV fluids. Sometimes they do albumin to help bind those fatty acids, and we'll put them on high-dose steroids. Compartment syndrome, basically hemorrhage and edema following a fracture leads to the inability of fascia to accommodate the excessive edema, impairing circulation. So basically, instead of swelling outward, it's swelling inward, pushing on those nerves and muscles. It can decrease circulation. Main symptom with that is pain, uncontrolled, unrelieved pain that is sharp or sudden. We're going to monitor those 6 P's. If we suspect compartment syndrome, we're calling that doctor right away. And we're going to loosen any type of dressing, any kind of cast, anything like that. And if we don't have any of those, we're going to prepare for a fasciotomy. That's where they cut open the skin and they basically leave that open until that swelling subsides. So this talks about the 5 P's, but I've been saying 6 P's. So basically these are your 5, and then we're adding in that poikilothermia. Most low back pain is caused by one of many musculoskeletal problems, such as acute lumbosacral strain, unstable lumbosacral ligaments and weak muscles, intervertebral disc problems, and unequal leg lengths. Some of the most common comorbidities that we see with back pain is depression, smoking, alcohol abuse, obesity, and stress. Generally, back pain due to musculoskeletal disorders is aggravated by activity, whereas pain due to other conditions is not. So the typical patient reports either acute back pain or chronic back pain. We all know that acute is lasting fewer than 3 months, and chronic is pretty much 3 months or longer without improvement. And they also report fatigue. The patient may report pain radiating down the leg, which is known as radiculopathy, or sciatica. That's that pain radiating from an inflamed sciatic nerve. Presence of this symptom suggests nerve root involvement. The patient's gait, spinal mobility, reflexes, leg length, leg motor strength, and sensory perception may also be affected. The physical exam may disclose paravertebral muscle spasms, which are greatly increased muscle tones of the back postural muscles with a loss of the normal lumbar curve and possible spinal deformity. So with the nursing assessment, we're going to get a detailed description of the pain, including location, severity, duration, any characteristics, does it radiate, and any associated symptoms such as leg weakness, description of how the pain occurred, and how the pain has been managed by the patient. We're going to assess their work and recreational activities. We're going to assess the effect of pain and movement limitation on lifestyle and ADLs. Is their back pain preventing them from getting out and doing things that they enjoy? Is it preventing them from getting their ADLs done? We're going to assess their posture, watching their position changes and watching that gait. And their physical exam, we're going to look at that spinal curvature, back and limb symmetry, movement ability, sensation, and muscle strength. If they are obese, we're going to complete a nutritional assessment of of the patient. All right, so this is a laminectomy is a procedure that they can use sometimes with patients with back pain. So basically it's the removal of the bone between the spinal processes and facet pedicle junction to expose the neural elements in the spinal canal. This allows for the surgeon to inspect the canal, identify and remove pathologic tissue, and relieve compression of the cord and the roots. The major nursing goals for patients with back pain include pain relief, improved physical mobility, and the use of back-conserving techniques of body mechanics, improved self-esteem, and weight reduction as necessary. So here are some ways that we can prevent that low back pain. Talk to our patients about that good posture, good lifting techniques, pushing objects rather than pulling them, making sure when we're carrying things we keep the load close to our body. We all know lift with our legs, not with our back, and bending at the knees and tightening up that abdomen when lifting. Okay, so we're going to get into osteoporosis and osteoarthritis. They're very similar, so how can we tell the difference? So osteoporosis is the loss of bone mass, which increases the risk of fractures, even those spontaneous fractures, whereas osteoarthritis is pretty much the degeneration of a joint. So when the rate of bone reabsorption exceeds the rate of bone formation, that's how osteoporosis develops. So our body is absorbing everything faster than we can make it. And therefore you get kind of that second picture there of that reduced bone mass. We get some bone demineralization because we have a decreased loss or removal of mineral constituents of our bones. And when we get to osteoporosis, or even that second picture, we could see patients that have compression fractures of the spine or fractures of the neck just because their bones are not able to support them like they should. There's two different types. Type 1 is postmenopausal estrogen deficiency, so our bones lack those minerals because our body's not producing that estrogen. And type 2 is when we think of bone health, we think of that calcium, so that's that calcium deficiency. Okay, we're going to talk to our patients early about preventing osteoporosis. We're going to make sure that they get enough calcium and vitamin D in their diet. We may have to provide supplements for them, tell them where to get vitamin D, where to get calcium, those kinds of things. Promote that weight-bearing exercises. The most popular one is walking. And to let them know that weight training stimulates that bone mineral density. So adding a little bit of weight to their exercise will help them prevent that osteoporosis. All right, so who's at risk for osteoporosis? We talked about menopause, so those postmenopausal women. Usually advanced age or low testosterone in men. Those that don't have appropriate amount of intake of calcium in their diet. High phosphate intake, such as those carbonated beverages. Those that are sedentary or have a lack of exercise, because we talked about the importance of those weight-bearing exercises. And those patients that are on corticosteroids, anti-seizure medications, long-term heparin, and kidney failure. How are we going to diagnose our patients with osteoporosis? The gold standard test is a DEXA scan. So that's looking at those bones, that bone mineral density that we talked about earlier. Serum calcium looks at the calcium levels in the blood, but not the actual bone. So when we're doing blood work, that really doesn't tell us too much about what's going on in those bones. We can also use x-rays to see how well the bones are doing. All right, our plan of care is going to consist of that bone density scan. We're going to assess their calcium and vitamin D levels, and if those are low, we're going to provide supplements for those. We may need to prescribe medications to prevent further deterioration, such as SERMs and bisphosphonates. Those menopausal women, we may have to prescribe estrogen to help decrease their incidence of osteoporosis. What kind of exercises are important? We talked about those weight-bearing exercises, and we're going to exercise fall precautions. We're going to assess for stress fractures, and some symptoms we look for that is low back pain. We may see fractures of the forearm, in the spine, or the hip. Okay, so some examples of bisphosphonates. You may have heard of Boniva or Fosamax on the TV commercials. And these are going to decrease the number and action of osteoclasts. They're going to inhibit normal and abnormal bone resorption, and these are going to be for your patients that have that postmenopausal osteoporosis or those that have it due to glucocorticoid use. Some undesirable effects of this, they may complain of headaches, abdominal pain, nausea, esophageal irritation. We're going to make sure that we do periodic DEXA scans and checking their calcium levels. And we're going to educate them. They need to take this with 6 to 8 ounces of water about 30 minutes before they eat. Do not lie down for 30 minutes after taking, and avoid dental work while taking this. We talked a little bit about this in a previous lecture, but that esophageal irritation can come if they eat and then lay down. They get that reflux feeling, which can burn the esophagus, and so that's why we want to educate them on all of these. So we talked about SERMs for a second. This is the raloxifene. And this has an estrogen-like effect on the bones and lipid metabolism. It reduces resorption of the bones and decreases that overall bone turnover. This is for prevention of osteoporosis in postmenopausal women. It also has a little bit of protection against breast cancer. With these medications, patients may complain of hot flashes, leg cramps, infections, and they have an increase for PEs and DVTs. Some interventions that we're going to do, we're going to discontinue this 72 hours before and during prolonged immobilization because of that increased risk. We're going to tell our patients to take this with or without food, and avoiding with the use of estrogens. We're going to take calcium and vitamin D supplements with these. Bone density scans about every month, every year to a year and a half, or 12 to 18 months, and promoting those weight-bearing exercises every day. All right, we're going to talk a little about osteoarthritis, which is the most common form of arthritis out there. The leading cause of disability. It can be very painful and it can worsen over time. It makes it hard for people to move, work, or enjoy normal activities. So osteoarthritis is also called degenerative joint disease. It's normally non-inflammatory, but sometimes you may see inflammation in those joints. It's a progressive deterioration and loss of cartilage in one or more joints, and as the cartilage and bone beneath begin to erode, the joint space narrows and osteophytes, which are bone spurs, tend to develop. Bone cysts and secondary synovitis are also common in advanced disease. Here are some common risk factors. So basically those over 60, you see it more in women, you see it with obesity, smoking, there has been a genetic link, and a history of repetitive stress on joints. All right, with the acronym ARTHR, for osteoarthritis, we're going to make sure that we assess their pain, administer analgesics, perform range of motion, and assess their ability to do ADLs. Remind them to use proper body mechanics and to perform splinting to protect joints if needed. Teach to use assistive devices. Try complementary and alternative therapies such as acupuncture or music. You need to rest between exercising, and we're going to do referrals to OT or PT, dietitian, whoever we feel that we need to refer them to. Treatment of osteoarthritis includes surgery. They will do that arthroscopy with tidal irrigation to wash out that debris from the joint space. And they may also do arthroplasty, replacement of all of or part of that joint. Arthroplasty is usually used only as a last resort for that pain, that unrelieved pain. Osteomyelitis is infection of the bone, and this can be real serious, and it takes a really long time to get that infection out of the bone. This usually occurs because of an extension of soft tissue infection, so they have infection somewhere around that bone area. It could be direct bone contamination. It could be bloodborne. It could be spread from another site of infection. And this usually typically occurs in an area of bone that has been traumatized or has lower resistance. A lot of times we see MRSA. Other types of causative organisms are Proteus and Pseudomonas, and sometimes E. coli. Alright, so with our assessment, we're going to assess any risk factors. We're going to look at signs and symptoms of infection, any localized pain, edema, fever, drainage, those kind of things. With chronic osteomyelitis, fever can be low grade, and a lot of times you see them like occurring at the same time every day, so usually in the afternoon or evening time. Signs and symptoms of adverse reactions and complications of antibiotic therapy. Um, we're looking for signs and symptoms of superinfections, and we're looking at the patient's ability to adhere to that prescribed therapeutic regimen, because it is usually a long-term treatment, and the patient needs to be very compliant with this so that we can, kill that bacteria in that bone. And a lot of times they go home with IV antibiotics as opposed to PO. So of course with anything, prevention is the main goal. Some other major goals with osteomyelitis include controlling that pain, improving physical mobility, controlling and eradicating that infection, and educating our patients on their therapeutic regimen. Some interventions, of course, relieving pain. Maybe we're going to promote immobilization, elevating pain meds, being gentle with the area, improving physical mobility. A lot of times activity is restricted, doing that gentle range of motion on the joints above and below the affected part, and making sure that we kind of get them to do as much as they can, but participating in the ADLs may be within their limitations. Other interventions, we may do prophylactic antibiotics a lot of times, especially on the ortho floor. If they're having any type of orthopedic procedure, they are going to have antibiotics sometimes before, even after the surgery, to prevent osteomyelitis. We all know hydration, vitamins, getting that good protein, education, long-term antibiotic therapy, management of home IV administrations, talking to them about any mobility limitations, post-op and follow-up care, and referrals for home health if needed. So how are we going to treat osteomyelitis? A lot of times they do that surgical debridement. They debride that infected bone area. They actually cut in there and get as much as that bacteria organism out of there. They may have to do a bone graft. So they'll remove that necrotic tissue, graft the bone, cover that skin, and making sure that we're doing sterile dressing changes every day for usually about 2 to 3 weeks.